this topic of oncofertility was something that, I'll tell you, this is what's interesting. Let me tell you a little background on how we designed these update courses. So the group of the course directors get together. We look at the papers that came out over the past year in JPS or in other journals. We sort of decide what are some things that are highly controversial, some new ideas, things that we think there's some gaps. Recently, APSA PDC has come on board to join us where they have their method of coming up with their gaps. What is fascinating to me is that this year, how many overlaps there were when we completely independently came up with our list. So umbilical access, complete independence, both of us came up with that. C-spine was one that we both came up with. And now this is the third one that we both came up with that we felt was important to talk about, and that is oncofertility. And we absolutely have an expert to talk to us about it. Dr. Julie Rios is our oncofertility expert. She's a OB-GYN here in Cincinnati Children's, and she's going to talk to us about oncofertility.
So I just went back to kind of what you guys, I think, were doing this morning with some cases. So this was an interesting case that we just had in the last month of an 11-month-old female that had a 3-month history of constipation, diarrhea, recent visualization of a vaginal mass. So she underwent a exam under anesthesia, cystoscopy, vaginoscopy, and biopsy of the mass, which revealed both urethral and bladder involvement. So looking at the mass, both urology and my partner in pediatric gynecology said, we think this is a bladder primary, and rhabdomyosarcoma was the final diagnosis. So we had a PET scan that was negative for lymph nodes. So the treatment plan is going to be this D9803, which is vincristine, actinomycin, and cyclophosphamide. And so we look at dosing of chemotherapy by what the equivalent is to cyclophosphamide. So that's what the CED means, cyclophosphamide equivalent dose. And it was 30.8 grams per meter squared. Anything over 15 in a pediatric patient puts them at high risk for ovarian failure in the future. She was also going to plan for GU radiation for local control. So our oncologists read her treatment plan, and we got a risk assessment of the primary ovarian insufficiency risk is high. She's planning to undergo laparoscopic lymph node dissection for further staging. So what would you offer this patient for fertility preservation?
Let's look at this. So it looks like there's your answer. It looks like everyone is saying ovarian tissue cryopreservation. Let's throw up a yes, no. The question is, have you heard of fertility preservation? Yes or no? Yes, you've heard of it. No, you haven't.
Yeah, so I'm just going to go to the next slide just to kind of go through our answers. So she's got two things going on. She's getting chemotherapy, which will affect the ovary, but she's also getting pelvic radiation, which will affect her uterus and her ovaries as well. So ovarian transposition or oophoropexy can preserve ovarian function from radiation damage, but the patient's receiving high-dose, highly toxic chemotherapy. Also in 11-month-old young patients, we may not actually get enough anatomic distance if it's pelvic radiation to really prevent that scatter. So that's always a question to talk to the radiation oncologist about, and to get the SIM to see what the scatter is going to be to those ovaries if we moved them. GnRH agonist therapy was something that we did, I would say not within the most recent years, to try to decrease fertility or increase fertility preservation during chemotherapy. It really has not demonstrated any clear preservation for patients. There is some benefit in older patients with breast cancer. Potentially, the studies conflict for that as well. But again, if we don't recommend this as our first line, ASCO does not recommend this as first line. And so if they have another option available, that's typically what we go with. So this patient was going to have another surgery. So ovarian tissue cryopreservation, it's experimental. It's followed by future ovarian tissue transplantation. That can allow for about 30% of patients to have fertility in the future. Most of the data, though, is from post-pubertal patients, but there have been studies to actually look at the ovarian tissue when we pull it out of the pediatric patients, and there's visible follicles. So there's lots of research, lots of hope that this will be something that's useful in our pediatric patients as well. And I just wanted to show a little bit of, what we do. So typically you can take a full ovary. You can also take a partial ovary. The tissue is harvested. The cortex is then cryopreserved. We typically do it within the same day to try to minimize any loss of eggs just from being out of their vascular supply. And then later in the future, it's an autologous ovarian cortical tissue transplant. Most of those go back in what we call orthotopic transplantation, where it's put back where the ovary came out. So you can sew it to the other ovary, which is what we see on the bottom, the very bottom picture, is the tissue strips are sewn to the contralateral ovary that remains. There's also a newer technique where you can just make a peritoneal pocket near the fallopian tube where you remove the tissue, put the strips so that the cortex where the ovaries will rupture from, their eggs will rupture from, near the peritoneum, and they'll just rupture right through the peritoneum. So there's different techniques, and it shows about 37 to 50% of patients that had a transplant had a live birth. 30 to 40% of people, so some people had multiple transplants, so 30 to 40% of patients will actually have fertility preservation, but 60 to 90% will have ovarian endocrine function. So it's very successful in that restoration, and that's data based on a meta-analysis.
So a couple questions. Not every place has their own gynecologists in their hospital. What could these 900 pediatric surgeons do at their hospital if they don't necessarily have a gynecologist?
So if this is something that the patient, I mean, you have to have the whole process. So even if you have someone that can remove an ovary, you have to have someone that can freeze it, because you typically freeze it on site. So there's lots of programs across the country and even internationally that do this. This actually became very, standard of care in the Netherlands as the first place that did this routinely. So all over the world, there's places that do this. And so if a patient's really interested in this, they can go for a procedure at a different hospital if they're stable enough. So we have patients come in just for this procedure, and then they'll go back for chemotherapy.
So for those of you in the room who may not have gynecology, I don't know if you all do, who does it at your hospital? I don't know if you all have gynecologists or not. Does everyone here have gynecology? Okay, so I guess answer in the thread, if you don't have a gynecologist, who does your ovarian cryopreservation? What about boys? What are we supposed to be doing? Do you do that at all?
I actually know. I don't do it, but I know about it. So again, for boys, it's also difficult because I didn't put on here egg freezing or sperm banking would be the equivalent, because until kids reach puberty, you can't get mature gametes from the body. So sperm banking is really only an option if they are post-pubertal. Typically, Tanner 3 and above is going to give us a better option for just banking sperm. If they're pre-pubertal and they're going to get high-dose treatment, there are some places, University of Pittsburgh has the protocol available, but you can do testicular tissue cryopreservation.
Okay,
yep.
That's what I was
wondering. And essentially, no one really does a whole orchiectomy, so it's just a wedge piece. Yeah, testicle. That's what we do here.
Wow.
So we have the protocol here, and we do it, and then we ship the tissue to Pittsburgh. So any place can actually open this protocol and then ship the tissue.
Okay.
Hey, Todd, can I ask a question?
Yeah.
So I missed about the transplantation. At what age is that done?
So we typically just do it for pregnancy because the graft is not equivalent to a full ovary. So it only is going to last somewhere between 2 and 5 years is what the studies show. So for hormone replacement, we just use medication for pubertal induction, as well as, hormones until they're ready to have pregnancy. And then we put the tissue back in specifically to get
So
pregnant.
it stays cryopreserved for whatever it is, 20 years or however long.
Yeah.
Just out of curiosity, is that cryopreserved here at the University of Cincinnati, or is that a private banking
So we used
service?
to do so we actually ship it off site. So pretty much every place now uses long-term storage facilities because they have the extra, cautionary, because you've heard about some of the instances of embryos or things being thawed out in Cleveland as well as in California. And so I think people like having that extra security. So most of the long-term storage facility has 3 or 4 mechanisms for detecting tank dysfunction so that doesn't happen. So ours goes to Minnesota, our tissue, but we process it in our pathology lab here.
Just explain what happened. So there was a hospital that lost their power supply or something?
Yeah.
And all of the embryos that were in storage, unfortunately.
I think in a couple of tanks. So it wasn't all of them, but just one tank.
That's why we need to maybe take some precautions. Yeah.
So who pays for it? And since these are young children who will move up and move away, how will they be tracked, or how will they know where their tissue is stored?
So our team just, so who pays for it? We'll start with that one. So the patient does pay for it. Typically for us, we try to team this with a different procedure. Most of our oncology patients are going to get bone marrow biopsy. They're going to get a central line port. So if we place that together, then the hospital fee and the anesthesia fee often can be covered by insurance because they're going to the OR for something else.
The tissue storage fee.
Oh, the tissue storage fee, that is the patient. So it is income dependent. So with anyone with an oncology diagnosis, if they make under a certain income, it's $75 a year. And then if they make more than that, then it's $275 a year.
Any other comments or questions? Okay, so